Good afternoon, everybody. It's my pleasure to be here this afternoon to talk about some of the medications that are used to treat multiple myeloma. I'll be going over the general approach to treatment, the most commonly used medications, including their side effects, and the regimens that these medications are a part of. I'll talk a little bit about a few of the supportive medications that myeloma patients often have to take as part of their regimens. At the end, I'd like to take a few minutes to show you how you might be able to find some of this information yourself on the internet. And as you guys mentioned, I did deliver a similar presentation back in 2016. There have been a few changes since then, which I've incorporated into today's presentation. And this time around, I thought I would take a slightly different approach compared to last time, because I think it might have been a little bit confusing. I want to focus a little bit more on the classes of drugs rather than on the individual drugs, given that drugs within a class often share many similarities. And I've also tried to streamline the information a little bit in an effort to keep things as clear and as simple as possible. So hopefully that will make a bit of a difference. So I'd like to tell you a little bit about McKesson. I've been a pharmacist there for 7 years now. And so few people seem to have heard of this company, even though it is a large corporation with extensive operations around the world. I can't tell you how many times I've had to spell out McKesson to patients when they're asking what pharmacy I'm calling from, because people just haven't heard about it before. So they say it's the oldest and largest healthcare company in the United States. It was founded in 1883 and currently has over 80,000 employees. In Canada, the US, and across Europe. It's publicly traded on the New York Stock Exchange if you're into stocks, and it's got a market capitalization of about 29 billion at the moment. It's a Fortune 8 company, so it means it has the 8th highest annual revenues of any publicly traded company in the US, so it's a rather large company. It entered Canada in 1991 when it purchased Medis from Provigo. Provigo, by the way, is now part of Loblaws. So for a long time, its main business in Canada was just wholesaling medications to pharmacies and to hospitals. But more recently, the company bought Rexall and PharmaPlus chain of pharmacies, which we're all familiar with. And it also bought the well.ca website where you can buy health and wellness products. And it owns the company that services the IDAs and Guardians and Medicine Shop and Remedy RX pharmacies, which are still independently owned. So altogether, it owns or serves about 15,000 Canadian pharmacies. So it's probably the biggest company that no one's ever heard of before. And this is the actual building that I work in here on Viscount Road near the airport. So McKesson in Canada has a specialty health division, and within that division, you'll find the pharmacy that I work at. And this is the pharmacy that some of you might receive your Revlimid or Pomalyst or Thalamid from. At the moment, the building that I'm showing here is a ghost town because most of the employees are on mandated work from home. But we as pharmacy employees still have to go in to get the prescriptions out the door and delivered to patients on time. So we're still very busy there in the basement getting prescriptions ready. And I just wanted to talk about a general treatment algorithm for multiple myeloma. So this is just an overview of how multiple myeloma is generally treated. So it's first diagnosed as either what they call MGUS or smoldering myeloma, or it might be diagnosed when it's already symptomatic. Smoldering myeloma and MGUS, these are just precancerous stages that don't require treatment, but do require monitoring. So physicians will do what they call watchful waiting, which is where they just kind of watch things and see if they're getting any worse. And once it actually becomes symptomatic, that's when they would initiate treatment. And once a patient is symptomatic, they're characterized into one of two categories. So they're either transplant eligible or transplant ineligible, depending on whether or not they're eligible for a stem cell transplant. And that really depends mainly on age, which with 65 years of age being the traditional cutoff, whereby patients above that age would not be considered eligible for a transplant, while those who were below were considered eligible. But it's not strictly about age. It also has to do with kidney function and how healthy patients are. So if you're older than 65, you might still be considered for a stem cell transplant. It's more about your health status rather than just your age strictly. Now, for patients who are transplant eligible, we would go down that middle tree there. And generally, there would be induction therapy using medication. That's a fancy word for first line, or the first therapy ever given to a patient. And that's usually done for 4 to 6 months, and then a stem cell transplant is done. That's where they collect stem cells, they kill them all off with high-dose chemotherapy, and then they reintroduce the stem cells into the bone marrow so that it can continue producing regular blood cells. And about 100 days after that, once the cell counts have recovered, this is when they would initiate maintenance therapy, usually using Revlimid. And that the goal there is just to prevent the disease from returning for as long as possible. Now, patients who aren't eligible for a transplant, so that's the last branch there on the right, they would also receive an initial first-line induction therapy. They typically stay on that therapy for as long as it works. There can be some type of maintenance therapy after that, but that's not really that common in Ontario. And unfortunately, in both cases, there's eventually a relapse where the medication just stops working, which requires what they call salvage therapy. And that's just really a fancy word for medication regimens that are used as second or third line therapy. And every time there's another relapse, or every time a patient is refractory to their current line of therapy, another regimen has to be tried, or maybe even another stem cell transplant for patients that are still considered eligible for that. Now, I'm going to go through a few slides coming up here, and I just want to show you that there's many combinations of drugs that can be used for this induction, for this maintenance, and for this salvage therapy. So the choices can seem overwhelming, and the options that I've listed there aren't even all the possible options. So the most popular options are really going to depend on where you live, what's covered by your public plan or your private insurance. It'll depend on what's endorsed by the local cancer agency, which is Cancer Care Ontario in our case. So I've really tried to just identify those regimens or combinations of drugs that are endorsed by Cancer Care Ontario and that are covered by the Government of Ontario, since these tend to be the ones that are used most often here. But ultimately, the choice, of course, is up to the oncologist, and it's going to depend on factors that are specific to you and what drugs you might have tried in the past. So just try not to get too overwhelmed here. I'm just trying to show you what are the most commonly used regimens in Ontario and why that might be. So these are some popular options that can be used first line, so as induction therapy in patients who are eligible for a transplant. The one that has bortezomib, dexamethasone, and lenalidomide, it's quite popular in the US apparently, and it works well. It doesn't seem to be covered in Ontario or endorsed by our cancer agency for this usage, so I don't think we see it very often here. And the same is true of the four drug regimens. So in the US, they're using these quad drug regimens or 4 drug regimens that combine a biologic called daratumumab, bortezomib, dexamethasone, and then either lenalidomide or thalidomide. And then there's also 3 drug combinations that have carfilzomib, dex, and lenalidomide, or just lenalidomide and dex. They're also popular in the US, and they might be used here sometimes, but there are coverage issues preventing their widespread use. So what I see most often in Ontario is the one that I've highlighted in blue there. They call it Cybor-D. It's got 3 medications in it called bortezomib, dexamethasone, and cyclophosphamide, and we'll examine that in a bit more detail later. That's still what I'm seeing most often as induction therapy, so first-line therapy in patients who are eligible for a transplant. Now, for those who are not eligible, so that's mostly patients over the age of 65 or older, the options are a little bit different. Many of the regimens you might notice include a drug called melphalan, which I talked a lot about in 2016, but I'm not going to talk about it this time because I find that they don't really use it anymore. It's a traditional cytotoxic drug that affects all cells that are replicating rapidly, including the plasma cells in the bone marrow. And it can be used in this situation because there's no planned transplant. But you can't use it for transplant eligible patients because it interferes with the mobilization and collection of stem cells. So that's why you see here a lot of melphalan, but you didn't see it in the previous slide for the eligible patients. The BMP, which is the top one there, used to be commonly used in Ontario for 9 cycles in a row. But nowadays, what I find is the most popular is just the dexamethasone and the lenalidomide on their own. So that's dexamethasone and Revlimid. It works better than BMP, and it's covered. It's endorsed by Cancer Care Ontario. So that's the go-to first-line option now for patients who are not eligible for a transplant. When it comes to maintenance after a stem cell transplant, these are the most common options here. So it's either going to be Revlimid, which is lenalidomide, or Velcade, which is bortezomib, or Ninlaro, which is ixazomib. But the most common option is just lenalidomide or Revlimid on its own, since that's what has the best evidence for efficacy, and it's also covered by the Ontario Drug Benefit Plan. Now, the other two there are sometimes used, especially in the US. They can be beneficial for patients who have what they call high-risk cytogenetics. So if you've got certain genetic markers that indicate that your prognosis might not be as good, then those are options. But the usage is limited again by the fact that they're not generally covered in Ontario. You might have to get it through a compassionate program. And these are the options for patients who have relapsed. So these are the same options for both patients who were eligible and who were not eligible for a stem cell transplant. So when you get to the point where the disease have relapsed, there are many options. And the ones that I've highlighted in blue are the most commonly used in Ontario. When I did this presentation again 4 years ago, the triplet regimens, so those are the ones that contained carfilzomib, dexamethasone, and lenalidomide, and daratumumab. They were starting to be used frequently, even though they weren't covered. So a lot of patients were getting those drugs through compassionate access programs from the manufacturers of those medications, but now they're all pretty much covered. So they're becoming much more mainstream and much more common.
Eric, can I jump in here?
Mm-hmm.
There is a question very quickly that you're talking about drugs currently that are endorsed by Cancer Care Ontario.
Mm-hmm.
What's the difference between the Cancer Care Ontario endorsed ones, and drugs that are on the Ontario drug formulary and funded by the province? Is that the same, or is there a difference here in the way they're supported?
Yeah, there's a difference. So
Thank
there are many regimens that are endorsed and published on the Cancer Care Ontario website, but that are not covered yet. So these are regimens that CCO acknowledges are helpful and effective, that are used in other jurisdictions, such as the US, but which haven't received funding yet. And in Ontario, you need funding for the infused drugs through what's called the New Drug Funding Program. So this is where the drugs are just shipped directly to the cancer clinics or the hospitals for free, so long as you meet certain criteria. Or the ones that you get delivered to your home or that you pick up at the local pharmacy, those are covered by the Exceptional Access Program. So that's the type of public drug coverage. So there is a discrepancy between the regimens that are approved and those that are covered. For the most part, the ones that are endorsed by Cancer Care Ontario do tend to have coverage, but certainly not all of them, as you can see from some of these tables that I've been posting here. They are probably the regimens that are most likely to have coverage one day, but not yet. So CCO is just trying to let the oncologists and the hematologists know what the best options are based on evidence, regardless of whether or not they're covered. There's also a discrepancy between what Cancer Care Ontario endorses, what's covered, and what is indicated by Health Canada. So that's another dimension. So you can have drugs like Revlimid for maintenance, for example. It's not actually officially indicated by Health Canada, but it is covered and it is endorsed by Cancer Care Ontario. So there's 3 organizations involved. There's Health Canada, Cancer Care Ontario, and then there's the drug plans, which are funded by the provinces.
you.
Okay,
Appreciate
thanks.
the clarification. Thank you.
Okay, so if we put this all together, here's a typical treatment plan for a transplant eligible patient in Ontario. So upon diagnosis, induction therapy will usually be started with 4 cycles of Cy/Bor-D. So that's the cyclophosphamide, bortezomib, and dexamethasone. That's followed by a stem cell transplant, which they officially call an autologous hematological stem cell transplant. Then about 100 days later, once the cell counts have recovered, maintenance therapy can be started with lenalidomide to keep the disease under control for as long as possible. Then when that disease returns, which according to the studies that were done usually happens on average after about 4 years, that is an average number or a median number, they can institute salvage therapy, most likely with one of the triplet therapies that I've listed in blue there on the bottom right-hand corner. Pomalidomide in particular, which is the Pomalist, it would be reserved for cases where both bortezomib and lenalidomide have been tried. So it's really for a second relapse. They call that third line therapy. So this is commonly what you might see in Ontario. And this is what you would see for someone who's not eligible for a stem cell transplant. So upon diagnosis, they'd be started with dexamethasone and lenalidomide, most likely. And then that's usually continued for as long as it works and as long as the patient isn't experiencing any serious side effects. And then when that stops working, the same salvage therapies that are used for the transplant eligible patients can be used. So we've had an overview of many different regimens, and we've seen where the most popular among these fit into therapy. But I've put up a lot of different drug names up there, and it might be a bit overwhelming. We haven't actually talked about any of the medications. So I want to do that now. And I wasn't really sure like what the best order would be. So hopefully, if we do it in this order, you guys won't be too confused. So let's talk about the drugs themselves. And I'd like to start by talking about a family of drugs called immunomodulatory drugs, or IMiDs for short. And these drugs do form the backbone of most regimens we looked at earlier. And the 3 drugs in this family are thalidomide, pomalidomide, and lenalidomide. You might know the lenalidomide as Revlimid, and the pomalidomide is Pomalist. And I'm going to talk about them together because they're similar in many ways. So they've all got the same mode of action or mechanism of action. So myeloma, it's as you guys know, I guess it's a disease of excessive plasma cell production in the bone marrow. And the plasma cells are a type of immune cell that secrete antibodies that attack antigens like viruses or bacteria. So all 3 of these drugs up on the screen here work by modulating the immune system, which ultimately suppresses the growth of these plasma cells in the bone marrow, which is helpful when you have myeloma. They're all similar in the sense that they're all taken by mouth once a day, either with or without food, and they're all capsules, as you can see from those pictures. They were all made by Celgene, but Celgene was bought out recently by Bristol Myers Squibb. So I guess you could say now that they're all made by BMS. And they all share similar side effects as well. So I've prepared a little chart here for you guys with the most common side effects of these 3 medications, so that you can kind of see like which side effects are more common in some drugs compared to others. So one of the most common side effects for all 3 medications is low white blood cell counts, which they call neutropenia. It's something that the oncologist will usually notice before you do, because they'll be measuring your blood cell counts regularly through a blood test called a CBC, or a complete blood cell count. So if the blood cells are below a certain threshold, then the CCO guidelines or the manufacturer guidelines will say that the medication should be held, and then restarted at a lower dose once that has improved. And a low white blood cell count does increase the risk of infections, including COVID. So it's important for anyone on these medications to take precautions. So we used to always tell patients, like, wash your hands frequently, avoid sick people, avoid large crowds, don't touch your face. These are basically all the things that we've all become accustomed to doing now anyways during this COVID pandemic. So I guess that's good training for all of us to avoid infections. And in extreme cases, there can be a serious condition called febrile neutropenia. So that's where you have a fever in the presence of low neutrophils or low white blood cells. And the fever could be caused by an infection in the blood. So it could be a sign of that. And it is considered a medical emergency. So if you've got a temperature, we tell patients if it's 38.0 degrees Celsius or higher for over an hour, or 38.3 degrees Celsius or higher at any point, then go to the emergency room to have that checked out. Those are temperature thresholds actually published by Cancer Care Ontario. And let them know that you're on a drug that can lower white blood cells. And if they determine that you do have an infection, they'll give you intravenous antibiotics. So it's not a good idea to go to the family doctor or a walk-in clinic for this kind of fever because they're not equipped to deliver intravenous antibiotics. And they suggest not taking Tylenol until you've been assessed because that would just mask the fever without resolving the underlying cause of that. And I've got another column there about fatigue. So that's another common side effect on these medications. And it's not really surprising because thalidomide was originally developed as a sedative. That was one of its original uses. So Revlimid or lenalidomide does appear to have more risk of causing this compared to the other two. And this is why they recommend taking all of these medications at bedtime. It'll be easier to fall asleep that way and there's less chance of being tired during the day. I do find that the fatigue tends to improve in time, so it usually gets better for patients after a few months of being on therapy. And some of the strategies to minimize that fatigue early on is just to stay active and busy around the home. Doesn't mean running a marathon, just having stuff to do is probably going to help boost your energy levels, like attending a myeloma group meeting, for example. Eating a well-balanced and nutritious diet and staying well hydrated can also help boost energy levels. And just try to do everything you can to get quality sleep. So sleep hygiene is quite important. Constipation and diarrhea are possible side effects with all three of these medications. They're most common with Revlimid. For constipation, Cancer Care Ontario suggests using Senokot or Dulcolax to start with. You can get those from any pharmacy. And just including sources of insoluble fiber in the diet. Those are things like prunes and oranges, whole grain foods, nuts and seeds, those types of things. And for diarrhea, the best option actually seems to be something called cholestyramine, which is also known as Olistar. So it's like an orange powder that you mix in water. And what cholestyramine does is it sequesters or binds bile acid in the gut. And the diarrhea caused by these three medications seems to be related to bile acid malabsorption. So it helps to take something like cholestyramine. Now, it does require a prescription, so you can't just go get it from the pharmacy. So at first, it might be worth just trying Imodium, which is the usual recommendation from the cancer agency. But if that doesn't work, don't hesitate to ask your oncologist or hematologist for the cholestyramine, because it has been proven to be the most effective treatment for that type of diarrhea. There is a rash. Now, the Revlimid in particular causes a unique rash. It's a dry, flat rash. It's usually not itchy. It can appear anywhere on the body, but it doesn't usually cover the whole body. It starts about 2 weeks after starting on the drug, and then it goes away on its own 2 to 3 weeks later. So it's not anything to worry about. It's going to go away on its own. In the meantime, if the skin's dry, you can try moisturizing it. You can also try treating it with like Benadryl by mouth or topical steroids like hydrocortisone cream, which you can get at the pharmacy. Or in extreme cases, the doctor might give you prednisone by mouth to treat that.
Eric?
Yeah.
Can I jump in for just a moment?
Mhm.
I'm just going to unmute Victor, who has raised his hand because he has a question.
Sure, yeah.
See if we can see if we can get that worked.
Yeah, there we go. I think
Awesome.
this may be a little ahead of things, but I've been experiencing some withdrawal symptoms when I have my break from taking the Revlimid. Like I take it for 14 days, I'm off for 7, and take it for 14 again. And this time I've just finished my 8th round. And today I'm not really bouncy, but I don't feel right, and my head's kind of foggy, and I just don't really feel with it. And I've noticed I've had this feeling before, but today is worse, and I'm just wondering because the drug is built up in my system, and then now I'm off of it for a week, and it's sort of reacting. Is that a normal reaction?
Mm. It is normal to have withdrawal symptoms after the dexamethasone is stopped, because the dexamethasone is taken just once a week, usually with most of these regimens at a high dose. And
Yeah, well, it's just interrupt. I have the dexamethasone just every Wednesday, and initially I had some irritation from it, but that's been fine. I've never had a withdrawal symptom, which I feel is what I'm experiencing now.
I haven't heard about that, Victor. I've heard about it with the dexamethasone. It's common for patients to feel very drowsy or lethargic for several days after they take it once a week, like you do. But I haven't heard of withdrawal symptoms when the Revlimid or the lenalidomide is stopped. Like if anything, patients actually feel better usually during that week, because the Revlimid causes that fatigue, which I've talked about already. Mostly that's what patients complain about. So they feel tired during the time that they're on it. Like for you, it's 14 days on, 7 days off. And then during their off week, they usually have a little bit more energy. So it's odd that like for you, it's the opposite. Like you feel good or better on the weeks that you're taking the Revlimid, and then the week that you're off, you have these types of withdrawal effects. But no, I haven't heard of these withdrawal effects before. But it is interesting that you're noticing a pattern. And you said you've done this 8 times and you've had the same effects every time?
I've just finished my 7th cycle. I'll be starting my 8th next Wednesday. And, I've noticed it a little bit, but it seems to be worse this time. And with the Dex, I had a problem sleeping the night I took it. The next day, I was just wound up like a $2 watch. I couldn't stop. I was just bouncing all off the walls. I see Robert's laughing there because he probably had the same problem. And I had boundless energy, and I was fine, But today, not so good. And to me, you're probably right because you're the pharmacist, but to me, it's the Rev.
Yeah, it's an interesting observation. Definitely there are withdrawal effects from the Dex. So they sometimes put people on a low dose prednisone on the days that they're not taking dexamethasone just to prevent that kind of fatigue and letdown after the dexamethasone. But there isn't the same type of letdown usually after the Revlimid. And what you describe with the Dex is very typical. I'll be talking about that later. But yeah, boundless energy, feeling on edge, not being able to sleep, those are very common side effects with dexamethasone.
Well, I'll talk to my oncologist again, and maybe I'll talk to there's a young lady named Bobby that works for the pharmaceutical company.
Okay.
She usually phones me once every couple of 3 months, so I'll talk to her and see if there's been any other report from some of the people taking it. But I'm sorry to jump in, but I just thought it was an opportune time to ask that question, and I appreciate you responding.
Yeah, see if Bobby knows anything about these types of withdrawal effects. I've talked to a lot of myeloma or Revlimid patients over the years, like many. I don't recall anyone else reporting a letdown from the Revlimid itself, usually from the steroid, which is taken once a week. But yeah, it's worth looking into that more for sure.
Okay.
I want to talk about the muscle cramps as well, because these are an issue with these medications. If it's truly a muscle cramp, it helps to take calcium and magnesium. Just make sure that your levels of calcium and magnesium aren't too high before you start supplementing. And they say it can also help to stretch or to stand if the cramps are in the legs or the feet, to have a warm shower or bath, to drink water. You can try massaging the area or applying a cold or hot compress to that area. They used to suggest quinine or tonic water, which contains a little bit of quinine, although it's not quinine, although it's not standardized. Those were options, but they're no longer recommended because the quinine is actually an anti-malarial drug. And there's a lack of evidence that it's effective for cramps. And at the same time, it increases the risk of bleeding and kidney damage and heart rhythm disturbances. So for those reasons, they don't suggest that as an option anymore. There is nausea and vomiting that's possible. It's a little bit less common than the other side effects. For mild nausea, some strategies include sipping on cool, clear fluids like water or apple juice, eating smaller but more frequent meals, and eating starchy foods like crackers or pretzels. If it's a more severe nausea, talk to the doctor about getting something for that. Gravol might help, but it tends not to work well for this type of nausea that's caused by chemo drugs. There's better options out there that can be prescribed for you. The nausea is listed there, but to be honest, in practice, I haven't had any patients call me to complain about that one. There's peripheral neuropathy, which is a fancy word for nerve damage. So there's 3 kinds of this peripheral neuropathy. It can be sensory neuropathy. So that causes tingling, pain, and numbness in the hands and the feet. And they say it has sort of a glove and stocking type distribution. There's the motor neuropathy, which can cause weakness and can cause people to walk in a weird way or have gait disturbance, or difficulty with writing or other fine motor skills. And there's the autonomic neuropathy, which can cause constipation and difficulty letting go when you're urinating. So all 3 types are possible, but the sensory neuropathy is the most common with these 3 medications. So the tingling, the numbness, and the pain in the tips of the fingers and the tips of the toes. Thalidomide is, as you can see by the green bar there, it is the most likely to cause that side effect. And that's one of the reasons it's not used very much anymore. If you do get peripheral neuropathy, or if you think you might have it, the suggestion is just to let the nurse or the oncologist know, because usually it's reversible if the drug is stopped quickly. But if you kind of ignore it and let it continue, it can become a permanent condition. And then the last column I have there is VTE, which stands for venous thromboembolism. So that's just a side effect that groups blood clots in the legs, which are called DVTs or deep vein thromboses, and blood clots in the arteries that are feeding the lungs. Those are called pulmonary emboli. So VTE essentially means clots in the legs or the lungs. They're not usually life-threatening, but they have to be dealt with in the emergency room. So if you've got pain, swelling, or redness in one leg, that could be a sign of a clot in the leg. If you have trouble breathing, shortness of breath, or chest pain, that could be a clot in the lungs. So in either case, they suggest going to the eMERGE to have that looked at. For this reason, there's usually a need to be on some kind of blood thinner when you're on these 3 medications to prevent blood clots. And aspirin is usually what most patients are on, so long as the risk of blood clots isn't too high. But if the doctor thinks your risk of blood clots is really high or higher, they may put patients on warfarin or one of these injectable low molecular weight heparins. There's one called Lovenox, and there's one called Fragmin. So either one of those could be options as well. And there's newer drugs as well, like rivaroxaban and apixaban that can be used. And then the last side effect that all these drugs cause is a birth defect, unfortunately. They call it phocomelia. This is what it looks like. It's just short or missing arms and legs. It's pretty tragic. It can happen if an unborn baby is exposed to any 3 of these medications in the womb. Thalidomide is the one that caused this tragedy originally in the 50s and early 60s when many babies were born with this particular birth defect. And it's the main reason that these drugs are only available through a controlled distribution program, which they call RevAid in Canada. So any patients who want to receive thalidomide, lenalidomide, or pomalidomide have to be enrolled in the program. Only certain pharmacies are allowed to dispense it. And only doctors who are registered in the program can actually dispense the medication. There's a lot of requirements for women who are of childbearing age who want to be on these 3 medications. They need to have pregnancy tests done on a regular basis, and they need to use 2 effective methods of birth control at all times, and for 4 weeks before starting and for 4 weeks after. So there's a lot of requirements for those patients. For men, they suggest that you need to use a condom when having sex with women of childbearing age, because the drugs are known to be present in the semen and they could cause birth defects if absorbed by a partner who's pregnant. And for the same reason, men cannot donate sperm while on these medications. When I go over these precautions with most men who are on Revlimid, they kind of laugh because patients do tend to be a bit older, but we do have some young patients as well. And finally, all patients must not share the drug or donate blood or allow women of childbearing age to handle it. And if there's any unused capsules, they need to be returned to the pharmacy that actually dispensed them. If you've ever gotten medications filled at our particular pharmacy, you may have noticed that these are things that kind of get repeated every time. Some patients find that annoying, but we have to do that. The manufacturer requires it, and it's our duty to prevent any birth defects such as these from occurring again. So we've talked a lot about the similarities. I want to talk a bit about the differences between the 3 medications that are in this class. So thalidomide was the first one. Then came lenalidomide or Revlimid, and finally pomalidomide in 2014. The newer ones do tend to be a bit more expensive. So Revlimid typically costs somewhere around $10,000 per month, and pomalidomide is a little over $11,000 per month. One particular thing with the pomalidomide is they suggest avoiding smoking because that actually decreases the efficacy of the pomalidomide. The drug interactions are somewhat similar. They all interact with estrogen and erythropoietin, which is an injection that's given to increase red blood cell counts, because those medications increase the risk of blood clots, as do these 3 drugs, as we just mentioned. Because thalidomide has a high risk of that neuropathy, it interacts with other drugs that cause nerve issues like lithium, vincristine, cisplatin, and bortezomib. And the beta blockers, which are drugs to lower blood pressure, and the donepezil, which is used for Alzheimer's disease, are also an issue with thalidomide, because they can all decrease heart rates the same way that thalidomide can. And there's a couple unique interactions with pomalidomide as well, with the fluvoxamine, which is a medication for depression, and the montelukast, which is used for allergies. In terms of adjusting doses, the Revlimid is eliminated by the kidneys. So if you do have kidney issues, or if your kidneys aren't working as well as they should, the dose will be lowered to compensate for that. And likewise with the pomalidomide, if your liver is not at 100%, they will reduce the dose of that as well. So here's a reminder again of where these immunomodulatory drugs fit in. The thalidomide is not there anywhere because it's not commonly used. The Revlimid is used for maintenance after the stem cell transplant. Or for people who are not eligible, it's used along with Dex as a first-line option. And then you will find lenalidomide and pomalidomide used in those salvage therapies there at the bottom. And these regimens look like this. So if you're using Revlimid for maintenance after having had a stem cell transplant, it's usually started at a lower dose of 10 milligrams per day. And it's usually taken continuously with no breaks, usually. And if you're taking it first line because you're not eligible for a transplant, then you'll be using that second regimen there, which is the dexamethasone and the lenalidomide. So in this case, the dexamethasone is taken once a week, usually at a dose of 10 tablets, although if you're older, they will reduce that to 5 tablets of dexamethasone, which is 20 milligrams once a week. And then the last regimen there with the pomalidomide, which is used in some relapse situations, is very similar to the dexamethasone and lenalidomide. It's pomalidomide at a dose of 4 milligrams to start with, usually, for 3 weeks in a row, followed by 1 week off. And then you've got the dexamethasone taken every week. So any of you who are on these regimens probably know this quite well. It's sort of 3 weeks on, 1 week off for either the lenalidomide or the pom, and then the dex is just once a week. The second major family of drugs is the proteasome inhibitors. They also form the backbone of many of these regimens that we saw earlier on. And there's 3 drugs in this family. So there's the bortezomib, which is known as Velcade, the carfilzomib, which is known as Kyprolis, and the ixazomib, which is known as Ninlaro. They all work in a similar way, or the same way, I should say. They're all metabolized in the liver. So if your liver is not at 100%, they will need to adjust the dose of the drug lower to compensate for that. And for the most part, they have the same side effects, which I've summarized in this slide here.
Eric, before you get too far along, can I jump back? Can you jump back 2 slides?
2 slides.
There's a question from Geraldine who asked, does the pomalidomide, does that contain ciprofloxacin?
No, no.
Okay.
No, ciprofloxacin is another medication altogether. It's an antibiotic.
Okay.
It's a broad spectrum antibiotic that's used for various types of infections, but it is not contained in lenalidomide for sure. Yeah, yeah, they're different drugs altogether.
Eric, it's Geraldine. Yeah. It was the slide before this one.
This one?
No, the one before that. There, on the right-hand side under pomalidomide at the bottom, it's an interaction.
Oh yeah, sorry. So I forgot to mention, yeah, it interacts with ciprofloxacin.
Okay, thank you.
But certainly not contained in pomalidomide.
Thanks.
Okay. So I created another chart here just to show you the most common side effects that are shared by all 3 proteasome inhibitors. So same way as we did with the immunomodulatory drugs. The peripheral neuropathy on the left there, that is an issue as well. The same way that it was with the thalidomide, the lenalidomide, and the pomalidomide. Again, it's usually a sensory neuropathy, so that's tingling, pain, and numbness in the hands and the feet. But it can be the other types of neuropathy that we had talked about as well. Bortezomib, which is the Velcade, has the highest risk of causing that. But that risk is substantially reduced when you give it as a subcutaneous injection under the skin instead of an intravenous injection. Because the bortezomib can be given either way, either as an IV injection or a subcutaneous injection. It's also more convenient to give it as a subcutaneous injection. So for these reasons, most patients are receiving the bortezomib as a quick injection under the skin. Mind you, the IV injection is pretty fast too. It's a 3 to 5 second injection, so it's not a big deal. As with the other drugs, it's important to report any tingling in the fingers or toes because that has to be caught early on, otherwise it does become a permanent condition. All 3 can cause issues with the gastrointestinal tract. So that includes diarrhea, constipation, and nausea and vomiting. They can all cause shingles. I didn't put a bar there for the carfilzomib because we don't know how commonly carfilzomib causes shingles, but it does. So they can, all 3 of them can do this. And the issue is when you catch chickenpox earlier on in life, that virus never really goes away. It just kind of lays dormant in the nervous system. And it can start to spread again at an opportune time. For example, when you're under stress or when your immune system is suppressed, or when you're on one of these drugs. So they call that shingles or herpes zoster reactivation. It's pretty painful and it can cause nerve pain that can last for years afterwards. So it's worth avoiding the shingles, and that can be done by taking an antiviral drug at the same time as these 3 drugs. Most commonly in Ontario, they use acyclovir, which I'll talk a bit more about later. They can all cause a rash, but the ixazomib is the most likely to cause that. It causes a red bumpy rash, and it can be treated with things like Reactin or topical steroids. They can all cause fatigue, especially the bortezomib, as you can see there. There are some other common side effects I didn't put on this slide that all 3 of them share. So they can all cause low blood cell counts. So that could be low white blood cells, which increases the risk of infections or fevers. It can be low platelets, which increases the risk of bleeding, and it can be low red blood cells, which causes anemia and might make you feel a bit tired. There can be swelling in the legs for all of them. There can be headaches. They can rarely cause an issue in the brain called PRES, and that's short for posterior reversible encephalopathy syndrome. It's an issue with the brain that can cause headaches, seizures, loss of vision, and an altered mental state. So if you're noticing anything like that on these drugs, just let the doctor know. And they can all cause something called Tumour Lysis syndrome, which I described here, but I'm not going to go into detail, I've decided, because it is a bit complicated. The main point here is that it's rare for all three drugs. It's more common with CLL, or chronic lymphocytic leukemia, but they do note that it's an issue with these three drugs in some cases. The main way to prevent it is to stay well hydrated. And really the issue is that when you start a new medication, like one of these, it can cause a lot of cancerous cells to die all at the same time. That releases potassium, phosphate, and purines in the blood. Ultimately, the main issue is what you see on the right-hand side, which is the acute kidney failure or kidney damage. So you want to stay well hydrated to prevent that particular damage. And they can also give something called allopurinol or rasburicase in some cases to reduce the risk of this. How are they different from each other? Well, the ixazomib is the newest one, released in 2016, whereas the Velcade was released earlier in 2005. They differ in the way that they're administered. So the bortezomib can, as we said earlier, can either be an injection under the skin or an intravenous injection. The carfilzomib, on the other hand, is always an intravenous infusion that takes at least 10 minutes. So it is a bit less convenient, it takes longer. And the ixazomib is the most, which is also called Ninlaro, is the most common of all, the most convenient of all. So it can be taken by mouth, just one capsule once a week. So that's quite convenient. They do suggest taking the ixazomib on an empty stomach because they say that high-fat meals can decrease the absorption of that drug. They're made by different manufacturers, and the bortezomib, they say, is best for patients who have kidney issues. This doesn't require any dose adjustments, and unlike the middle one there, the carfilzomib, it doesn't cause renal failure. Bortezomib does have the unique characteristic of interacting with vitamin C supplements and green tea, which I listed under the drug interaction row there. So they suggest avoiding vitamin C supplements, not necessarily foods that contain vitamin C, and green tea when you're on that. They each have some unique side effects as well. So if you're giving the bortezomib as an injection under the skin, which is the most common way of doing it, there can be what they call an injection site reaction. So that's just a little bit of redness, pain, and swelling right where the needle was injected. They say that this can be minimized by rotating sites so that the nurse isn't injecting in the same place every time. The nurses should know this anyways, but you can let them know if they're injecting in the same spot. And you can try applying a cold compress as well, or something cold to that area after the injection so that you don't have this problem as much. The ixazomib, or Ninlaro, has a unique issue with eye disorders. So it can cause blurry vision, dry eyes, inflammation in the eyes for about 26% of patients. So that's unique to that one. And the carfilzomib in the middle there, it's got a lot of unique toxicities or side effects. So one of the issues is it causes cardiac problems, including, and not commonly, but it can, including congestive heart failure, high blood pressure, arrhythmias, narrowing of blood vessels, including heart attacks. So they do suggest before starting the carfilzomib or Kyprolis that any cardiac issues be dealt with, including getting blood pressure under control. And it also has these unique pulmonary toxicities or lung issues that can include breathing issues, coughing, infections in the airways, pneumonia, things called pneumonitis and interstitial lung disease, which are other lung problems, and something called acute respiratory distress syndrome. So it does have those lung issues. It can cause renal failure. And perhaps most importantly of all, it can cause what I referred there as IRR. These are infusion-related reactions. So there are things that happen either during the infusion, shortly after, or even up to a day after the infusion. It includes a lot of allergic reactions, things like fever, chills, muscle pain, facial flushing and swelling, shortness of breath, vomiting, weakness, low blood pressure, and chest tightness. So that is an issue with that one. Now, that issue can be mitigated a little bit by giving the infusion more slowly if necessary, by making sure patients are well hydrated by drinking water and through intravenous hydration as well. And this is also why they give dexamethasone usually anywhere from 30 minutes to 4 hours before the infusion, just to prevent those types of reactions. And some of the regimens that use these are the Cyborg-D, which we talked about already a little bit. So that one's got bortezomib in it. And then there's a couple regimens that are often used for relapse or as salvage therapy. There's one that's got carfilzomib along with lenalidomide and dex. And there's one that has ixazomib along with lenalidomide and dex. And this is just a quick summary of the Cyborg-D regimen. So we were mentioning earlier in the presentation, it is used as a first-line option for patients who are eligible for a stem cell transplant, usually just for 4 cycles. It includes these 3 drugs here. So there's the dexamethasone that's taken once a week after breakfast. Then you typically go to the hospital, get the bortezomib injected. And then when you come home, they'll probably give you ondansetron, which is an anti-nausea drug. And then half an hour later, you can take the actual, you can take cyclophosphamide, which is a traditional chemo type drug. With the cyclophosphamide, you need to stay well hydrated to prevent bladder toxicity. And this is a regimen that is used for relapse, which was at the bottom of 2 slides ago. It's the Revlimid and the Dex the same way that you normally find it. So Dex once a week and Revlimid for the first 3 weeks out of 4. And then there's carfilzomib, which is usually given the first 2 days of the week for the first 3 weeks of the first 12 cycles. And then for cycles 13 to 18, they say it should be given the first 2 days of the week, but only for the first and second week of the cycle. And then the 4th week is a week off for all of the medications except the dexamethasone. And then this is the other regimen that includes ixazomib or Nanlaro, again for relapsed myeloma. The lenalidomide or Revlimid and the Dex again are given the same way with the Revlimid 3 weeks out of 4. And the ixazomib is also 3 weeks out of 4, but it's just 1 capsule on those days. So there is one biologic that's used to actually treat multiple myeloma. It's called daratumumab or Darzalex. And it's an antibody, like many of these biologics are. And it's an antibody that's produced by a manufacturer, not by a human. And it binds to a protein sugar that's actually on the surface of the myeloma cells in the bone marrow. And once it's binded to those protein sugars, it either directly kills the myeloma cells or it causes them to be destroyed by the body's own immune system. So it kind of tags them for destruction by your own immune system. So it's a way of manipulating your immune system to fight the disease. It was approved in 2016, and it's made by Janssen. And it is a lengthy infusion though. So about 6.5 hours the first time, 4 hours the second time, and about 3.25 hours on subsequent infusions. Some of the side effects for it are fatigue, bleeding, nausea, vomiting, muscle pain, cough, trouble breathing, fever, runny nose, and diarrhea. It can cause infections, so it's known to cause certain infections that are usually rare, like listeria, for example. So for that reason, patients are usually on an antibiotic at the same time as being on this medication, often the one called Septra. And so that could be an issue with live vaccines. I'll have to look into that since we've been talking so much about vaccines, but let's hope that it's not a live vaccine, the COVID vaccine. And like the other proteasome inhibitor, or like the proteasome inhibitors, it can increase the risk of shingles. So with this one too, they recommend acyclovir or an antiviral of some sorts to be taken at the same time. It can cause infusion-related reactions, like the carfilzomib that we just talked about. It includes things like trouble breathing, nausea, rash, and low blood pressure. So there are medications that are given before the infusion to deal with this, including dexamethasone. So dexamethasone is usually, it's part of the regimen that daratumumab is a part of. And usually we see the dexamethasone just once a week, right? But with this regimen, they give half the dexamethasone the day of the daratumumab, at least half an hour before, and then they give the other half the following day. And that's to prevent some of these infusion-related reactions, like the anaphylaxis or the trouble breathing or the nausea, because dexamethasone also helps with nausea. It can help with low blood pressure and rash. So it helps with all the infusion-related reactions that this one can cause. They also usually give Tylenol before the infusion and Benadryl. Sometimes also Pepcid and Montelukast, which are, and Montelukast is an allergy medication, as is Benadryl, and Tylenol helps prevent fevers. So there's a whole bunch of medications that are given before the infusion. There's a little bit of dexamethasone the day after, all to prevent those types of reactions. And there's the antibiotic that's taken along with it to prevent infections. And there's really mainly one regimen that seems to have this. It's the daratumumab at the bottom there with the lenalidomide and the dex. And that regimen looks like this. It's a complicated regimen to explain to patients because, and for us to keep track of at the pharmacy, because the daratumumab dosing is different depending on what cycle you're on. So is the dex dosing. So the daratumumab is given once a week for the first 2 months or 2 cycles. Each cycle is 4 weeks long. But then after the second cycle, for the next 4 cycles after that, it's given every other week. And then after that, so for cycle 7 and beyond, it's given just once every 4 weeks. That's going to change the dexamethasone too, because the dexamethasone is given half of it the day of the daratumumab, half the day after. But if you're on cycle, say 3 to 6, you're only going to be getting the daratumumab every other week. So on the weeks where you're not receiving daratumumab, that dex is actually taken all on one day. It's not like split up between 2 days. So it's complex to explain to patients, and it's difficult for us to keep track of what cycle patients are on if we're trying to blister pack the dexamethasone, for example. But we try our best to do that. The Revlimid is simple in this case. It's the same as usual. So the lenalidomide is taken once a day for 3 weeks out of 4. There would, on top of all that, there would again be that acyclovir to prevent the shingles. There would be aspirin, most likely, to prevent blood clots from the dexamethasone and the lenalidomide. There'd be an antibiotic to prevent infections. So quite a few medications as well to go over with patients. We didn't talk about cyclophosphamide yet. It's an old drug, which was first approved in 1959 in the States. And it's a traditional cytotoxic drug. So that means it indiscriminately affects all cells that are rapidly dividing in the body. So that includes plasma cells in the bone marrow, which is helpful in multiple myeloma. But that also includes hair follicles. So the drug actually causes hair thinning in about 100% of patients, but it only causes severe hair loss in maybe a third of patients at most. And because it's affecting all cells that are rapidly dividing, it's going to affect other cells in the bone marrow. So you could get low platelets, you could get low red blood cells and low white blood cells. And it includes cells that line the gastrointestinal tract, so it can cause mouth sores and diarrhea. Like many traditional cytotoxic drugs, it can cause nausea and vomiting. So that's why the physicians or the oncologists will often prescribe ondansetron to be taken half an hour before the cyclophosphamide to prevent that nausea and vomiting. And patients are often given prochlorperazine as well, which is another anti-nausea drug. And that one is just to be kept on the side and taken as needed for nausea and vomiting. Officially, they say that it can be taken with or without food, but best to take it with a bit of food to help prevent that nausea. And the one thing that it's known for is a type of bladder toxicity called hemorrhagic cystitis. So the issue is, as I've described at the bottom there, the cyclophosphamide is not actually an active drug. It has to be converted in the liver to the drug that actually has an effect, which is called phosphoramide mustard. At the same time, it's also converted to an inactive metabolite called acrolein. and that accumulates in the bladder and causes this issue. So the main thing to remember to prevent that is to stay well hydrated. So drink a lot on the day of and for a couple days after. That ensures that the drug is well diluted in the bladder, so it's not too concentrated, not too irritating. It forces you to go to the bathroom frequently, which means it's not staying in the bladder. And for this reason, you don't want to take the cyclophosphamide too late in the day either, because then the drug will be sitting in the bladder overnight and potentially causing that hemorrhagic cystitis. Because it is a cytotoxic drug, they suggest washing your hands after handling it. Otherwise, it might irritate the hands a little bit. And it does have an interaction with grapefruit. So it suggests that you avoid grapefruit when you're on that. And again, the main place you're going to see this is in that Cyborg-D regimen that's used top left corner there as a first line option for patients who have just been diagnosed with multiple myeloma and who are considered eligible for a stem cell transplant. So I want to talk a bit about the DEX because it's part of so many regimens, right? So it's combined with the lenalidomide or Revlimid, it's combined with the pomalidomide, it's combined with those proteasome inhibitors. So it really forms the backbone of many myeloma regimens. And before we had a lot of these options, like dexamethasone was just considered standard therapy on its own. Apparently, that was before my time, because it suppresses the immune system and helps control the growth of plasma cells in the bone marrow, which is helpful if you have multiple myeloma. It is what they call a corticosteroid. So it's got what they call glucocorticoid effects and mineralocorticoid effects. The mineralocorticoid effects include things like retaining salt and water and losing potassium. And the glucocorticoid effects are the ones that really bother people. So these are things like increased blood sugar. So if you have diabetes, you might notice your blood sugar is rising a little bit around the time of the dexamethasone. But apparently you don't need to really worry about it if it's just the day of the dexamethasone. It can suppress the immune system a bit. And it's got these psychological issues, which is what really bothers people. So the main thing people complain about on this is the trouble sleeping. I think Victor had mentioned that. So yeah, it's almost impossible to sleep the night of, especially if you're on a higher dose of dexamethasone. What some patients do is they take advantage of that to get stuff done around the house. So they might do their laundry at 3 in the morning, for example, or do their taxes or something. And then the next day, they haven't slept, for 24 hours at that point. They usually crash the next night and sleep fairly well. Or sometimes it can linger for a second night, and then after that, it's okay. Taking the Dex in the morning as early as possible should help to minimize that particular side effect. And then there's other psychological issues like depression or anger or irritability, thoughts of harming yourself or others. People feel anxious, on edge. They might feel on top of the world as well. Some people feel like they want to gamble or spend money freely. So it can change your personality. It can make you angry or short with people. And I think I told this story last time. There was a patient who was on dexamethasone, and her husband called me. He said, my wife's going crazy. She's breaking things. She's throwing things. And this only seems to happen on the days of the dexamethasone. And I was like, yeah, that sounds about right. So in that case, that there are options like there are benzodiazepines that can be used to help patients sleep better, or maybe melatonin. And there can be things to calm the nerves a little bit, or they can try reducing the dose of the dexamethasone. And it should be taken with food as well to prevent the risk of ulcers and nausea, which it can sometimes cause. And I wanted to say a few words about the other supportive medications. So something that a lot of patients are going to be on is aspirin to prevent blood clots caused by dexamethasone, and the Revlimid or the lenalidomide that we were talking about. So it's really an old drug that I think was approved in 1897 in Germany and invented by this guy here, Felix Hoffmann. Usually it's a low dose, so just 81 milligrams, although there's apparently some doctors in Ottawa that prefer 325 milligrams as a dose, but most physicians will choose 81 milligrams. It's best to take it with food to prevent ulcers in the stomach. They are enteric coated, which is supposed to help protect the stomach, but it's still helpful to take it with food. And you wouldn't want to take it with any other blood thinners. So if you're already on something like warfarin or Fragmin or Lovenox or rivaroxaban or apixaban, those are some of the new oral anticoagulants, there's no point in being on aspirin. You've already got enough prevention of thrombosis that you don't need to be on aspirin. And it can increase the risk of bleeding, but not usually at this dose of 81 milligrams a day. But if you do have any bleeding, let the doctor know. And then this is this other supportive medication that we already talked a lot about, the acyclovir. So I think in BC they use valacyclovir as part of their regimens, but here it's acyclovir because it's covered. So you'll see it given with the proteasome inhibitors, so with bortezomib, carfilzomib, and ixazomib, and with the daratumumab, because all of those increase the risk of shingles. That's kind of what shingles looks like, I guess, in some people. The usual dose is going to be 400 milligrams twice a day. So that could be half of one of those blue tablets you see in the top left corner. Those are 800 milligram tablets. Or it could be one of those pink ones, preferably. You just take one of those pink 400 milligram tablets twice a day, either with or without food. But food can help because sometimes it can cause a little bit of nausea and vomiting. But like I mentioned, it's really low risk. It doesn't cause many side effects at all. So it's worth being on it. They usually continue it for quite a while after those drugs are done. So if you finish bortezomib, the doctor might ask you to stay on it for up to a year afterwards because the risk of the shingles remains elevated for that long. And the last category of supportive medications I want to talk about is these medications that are used for the bone. So there's three of them. There's pimidronate, there's zoledronic acid, and there's denosumab, which is also known as Xgeva. So the way they work is that there's cells in the body that lay down new bone. They're called osteoblasts. And there's cells that break down bone called osteoclasts with a C. So in myeloma, there's kind of an imbalance between these, and it leads to increased osteoclast activity, which results in these lytic bone lesions or these holes in the bone, which can then lead to bone fractures and bone pain and high calcium levels in the blood. And I think this is how most patients are diagnosed with myeloma, is they have some kind of back pain or perhaps a fracture in the vertebral column, and then they go to the doctor and then the tests are done and they find out they've got myeloma. So it is common. They say 80% of patients on myeloma who have myeloma have issues with bones. So to prevent those issues and to lessen bone pain and to improve quality of life and survival, they will put patients on one of these three drugs. The first two, the pimidronate and the zoledronic acid, have a very similar mechanism of action. They're part of a drug family called bisphosphonates, and they reduce the activity of those osteoclasts, which helps to strengthen the bones. They're both intravenous infusions, and both are given once every 28 days to start with. That can be reduced to once every 3 months after 2 years of treatment, or if everything's good after 2 years, they can just stop it altogether at that point. The zoledronic acid is a quicker infusion because it can be done in as little as 15 minutes, while the pimidronate takes 2 to 4 hours to be infused. They can both cause flu-like symptoms, decreased kidney function, and this feared osteonecrosis of the jaw. That's what all those pictures there are about. So the osteonecrosis of the jaw, it looks pretty bad. It's dying bone in the jaw, which looks like this and which is exposed. It's usually triggered by dental surgery. So as long as no one's going in your mouth and doing anything, you're usually safe. But if you're going to get some kind of dental work done, this can start after the dental work. And in fact, as many as 10% of patients who are on the zoledronic acid can get this osteonecrosis of the jaw. They can treat it by cleaning the area or giving you antibiotics, but the treatments aren't great. They don't work that well. They're less than optimal. So the key really is to talk to your dentist before you get the surgery and ask them if they think you should hold these drugs, all three of them. So that's the best thing to do. And then if it needs to be held, that's what will happen. And that will significantly reduce your risk of getting this particular issue. The denosumab also works by inhibiting these osteoclasts. And the interesting thing with the denosumab is that they find that it actually helps slow down the progression of myeloma on top of strengthening the bones. So they think that it might have some kind of anti-myeloma effect itself. It's a quick injection every 4 weeks, but it does increase the risk of having low calcium, and so they suggest keeping supplementing with calcium and vitamin D to prevent that. And it also has the risk of osteonecrosis of the jaw. So in summary, the one that most patients are going to be on is the pamidronate, because it's covered in Ontario for everybody. The zoledronic acid, it's only covered for those who can't tolerate pamidronate. So kind of a second line option. But some hospitals are just paying for it out of their own budget because they find that it's so much faster to administer. It only takes 15 minutes instead of 2 to 4 hours. So it might make sense for the hospital to just pay for it themselves and get the patient out the door faster rather than like tying up the nurses for 4 hours to infuse a pamidronate infusion, which is covered. And then the denosumab or Xgeva is not covered at all, so you probably won't see it as often. So yeah, I was just going to give a very quick tour to show you guys how you can find high quality, reliable, accurate drug information on the internet for free. Because our first tendency often is just to use Google to search for drug information. That usually results in finding questionable websites that might not be trustworthy. So I want to show you how to find good information on the Health Canada Drug Product Database and through Cancer Care Ontario. So I'm just going to share my browser window. The Health Canada Drug Product Database, that contains the regimen, or sorry, that contains the drug monographs for all medications that are approved for sale in Canada. So you can just search for Health Canada Drug Product Database in Google and click on the first link that you get. And then just say that you want to access the database. And then search for the product. So if you're on Revlimid, for example, you might search for that. You can search by brand name, or you could put lenalidomide in this other field here. And then you can search. And you'll find all the strengths of Revlimid that are approved for sale in Canada. If it says marketed, it means it's available most likely on the Canadian market. You've got the drug identification number, the manufacturer, and you would just click on one of these. And then the key document is this here, the product monograph. So once you open that, this is the official information that's published by the manufacturer. So in there, you can find a summary of the product information, what it's approved for in Canada. So that's the Health Canada approved indication, any warnings or precautions. There's a whole section, very detailed. You can see it goes from page 16 to 40 about adverse drug reactions. So those are side effects. So you can see what side effects happened and how frequently they happened in the various studies that were used to approve the drug. You can read about the drug interactions. You can see how it's dosed and administered, how to store it, how to handle it, how it is packaged and how it comes. And there's also the part 3. This is the part that is often distributed with the product itself. So that's more geared towards patients. It's a little bit easier to understand. But this is the same information that your physician or pharmacist is likely referring to most of the time. So you can actually go in there and just read it directly yourself and skip the middleman if you want. But it can be hard to interpret. So you may need help from your pharmacist or your doctor to interpret the information that's in there. And the second resource I wanted to talk about was the Cancer Care Ontario website. So just search for Cancer Care Ontario in Google, and you can go to their main page. And Cancer Care Ontario also has information about drugs, similar to the manufacturer's product information, but it's a bit more condensed, and it may have some information that the manufacturer doesn't have. And it also has the regimens. So all these regimens we've been talking about, like the Cyborg-D or the dexamethasone, lenalidomide, and carfilzomib, like those regimens will all be described on this website. So you want to go to drug formulary at the top, and you can either search for the drugs or the regimens. So let's look at a regimen, because that's something that you can't find in the Health Canada Drug Product Database. So if you wanted, for example, the regimen that combines daratumumab, the one that Eric was on there, the daratumumab, the dexamethasone, and the lenalidomide. You could just try searching. There's a couple ways. You can search by condition. So you can go cancer type, hematologic, and then just refine it so that you see only the multiple myeloma. So there's 40 regimens that are endorsed officially and published by Cancer Care Ontario. And then you can find that regimen. So that one is probably called DARADEXALENA because it's got those 3 medications in it. So here it is. So it's DARADEXALENA. It's used for multiple myeloma. It contains these 3 drugs, daratumumab, dexamethasone, and lenalidomide. And you can go to the regimen monograph. And that will be a full description of the regimen. So it shows you what it is. It shows you the daratumumab is taken at this dose intravenously once a week for the first 2 cycles, right? And then for the next 4 cycles, it's taken only on days 1 and 15. And then after that, it's taken just 1 day. And it shows you how the dex and the Revlimid are taken. It shows you how long the cycles are. It shows you what other drugs you should be on. So they're saying consider acyclovir for shingles prophylaxis. Consider aspirin to prevent blood clots. And so the doctors and the pharmacists at the hospital or the cancer clinic are using this as well to remind themselves as to what they should be prescribing. It's telling you that you should be splitting the dex, that you should be on Tylenol, that you should be on Benadryl, that you should be on Pepcid and Montelukast potentially to prevent those infusion-related reactions. And it tells you when the doses should be monitored. So if you're having a symptom and you're wondering whether that might warrant a dose reduction, that will be in that particular section there. And you've got all the side effects that the regimen causes. And that's a combination for all the drugs that are part of the regimen. So you don't have to go look them all up separately in different regimens or different monographs. They're all combined here in this table for you. And there's information about drug interactions. And if you're wondering about coverage, you can just click on the drug. Like say it's daratumumab that you're interested in. How is it covered? You can see down here, it's covered under the new drug funding program. And you can go in and see like what the criteria are for the daratumumab funding. And that's what the doctors would be looking at when they decide whether you qualify for coverage and whether they can actually go ahead and prescribe it. So those are like high quality sources of information that are better usually than just Googling your question. And they're the same references that your healthcare providers are using for the most part. So you can go in there yourself and find that information.